So thank you everybody for joining. This is another webinar in our series of the Carousel Care campaign. Today we're going to talk about caring for the caregiver. These are our planning committee members. And then just a couple of logistics. So FYI, this is being recorded and will be available after the webinar. This is the link to our site where you can find all of the recordings of the webinar. I'll place that in the chat. And then just FYI, we will have some time at the end for a question and answer portion. And just to help streamline that, it would be great if you could direct any questions you have in the chat to me. My name's Olivia Ruth. As a reminder, we in these webinars always strive to talk about families in an inclusive way. So making sure to be mindful that, a traditional family is thought to be comprised of a mom and a dad, but families are built in many ways. So we will do our best to use inclusive language in our discussion today. And I'd like to also introduce our content experts. So we have Kara Hansen, who is a clinical social worker at Children's Mercy and works in the Fetal Health Center and with the neonatology group, of course. Amy Bockham, who is a psychologist at Nationwide Children's Hospital in the NICU. And Dr. Profit, who is a neonatologist at Stanford University and will be starting off our presentation. So I am going to allow him to share his slides and get us off to an excellent start.
Yeah, good morning, everybody. You can hear me and see my slides well, I'm assuming.
Yes.
Okay, great. So yeah, it's such an honor to be here this morning. As you know, the Carousel Care initiative really is trying to support family mental health. We thought one really important component of supporting family mental health is to also support a healthcare worker mental health. And so today's presentations will be all in that theme. And I'm covering a small piece about one portion of healthcare worker mental health, which is burnout. I have a couple of disclosures, mostly that some of our work was funded by NICHD, specifically also with regard to burnout and healthcare culture. So what is burnout? Well, essentially, burnout at its core is the impaired ability for us to experience positive emotions. And so if there's something that is funny or like a positive thing, we will oftentimes not interpret it as such or not give it the amount of due that it really should have in our lives. So we, as human beings, we naturally focus on the negative, on the things that we're afraid of. Like biologically, it's more important for us to run away from a saber-toothed tiger than to cuddle like a cute little doggy or something. So we avoid dangerous things, and we're more likely to remember forever dangerous things in our lives and interpret things that are negative over the positive. And so burnout essentially is a syndrome that's related to work, where people have the sense of sort of running out of power, running out of gas, and is traditionally measured through surveys. And Elizabeth Maslach was the kind of pioneer really in this space, and she really defined surveys around kind of three major themes: emotional exhaustion, depersonalization, as well as a reduced sense of personal accomplishment. In our work, we have mostly focused on emotional exhaustion because it seems to link most cleanly with things that we care about in healthcare in terms of clinical outcomes or organizational outcomes, though the other domains also are important. However, no healthcare worker likes to complete a whole lot of surveys, and so by just focusing on one domain, we've been able to kind of limit responses to just 5 questions. And so the elephant in the room, of course, over the past couple of years, well, maybe did any healthcare worker experience any stress in the last couple of years? Well, we've had this small thing called the pandemic. And that's like upset all of our lives. There's been numerous other things. I live in California, so for us, every summer the sky is orange, and the kids can't breathe and can't go to sports activities because of fires. And so there's like all of you can probably identify a whole bunch of other things that have been stressful over the past couple of years that have sort of compounded your lives. So before we came into the pandemic, about a third of healthcare workers experienced what's called severe burnout symptoms. So if you're in a room somewhere and you look to the left and you look to the right, like one of these, the three of you had severe burnout. And then maybe even just like shortly before the pandemic, at least for some physicians, those rates increased to about half on national surveys of physicians. And so there was kind of a trend towards increased burnout and really an impetus to do something about it beforehand. Now, in the pandemic, this has now risen to about 2/3. So now you're in the same room with one person to your left, to your right. Now, two of you are severely burned out. And I'll show you about some of the consequences that has. And Iman Haidari was one of our fellows that she published this data, which we initially thought like, well, maybe this was a survey of, neonatal and OB providers, and the response rate really was not that great. And maybe this is just a biased sample. And so we looked at other data sets that we had access to. And here's a data set of more than 35,000 healthcare workers in which we could do longitudinal tracking over a number of years. And you may remember that like early in the pandemic, really there was healthcare workers were kind of the heroes. Remember when people were like clanging on pots and pans and like hooray for healthcare workers who are so brave. And there were a number of articles, including the New England Journal, that sort of suggested, well, maybe really the pandemic is like an antidote to burnout, because now physicians can find meaning in their work again, and they're really just taking care of patients rather than dealing with all the things that are part of our healthcare worker lives that really don't add much meaning or much value to patients, all the administrative and clerical work. So in fact, when we look, the gray number here on this side is physicians, and the green and the orange are either other workers or nurses. You could see that for nurses, this improvement was not true. They just got worse throughout. And here we're looking at emotional exhaustion, and on the right here, it's emotional exhaustion climate, which is when we ask you about whether your colleagues are burned out. And so you can tell, like when you talk about yourself, your rates are lower. Your colleagues, like those other people, they're a lot more burned out. And so the 2/3 number actually kind of turned out to be maybe about accurate, even from Dr. Haidari's study, because here our response rates are about 70 to 80%. They're all very good. But physicians initially, in fact, there was a little bit of improvement here, but now substantially worse. And the same if we ask about others. So things are worse now, and we might all be feeling this, and it's important because burnout has a lot of negative consequences. On the personal side, it can lead to broken relationships. There's a strong association with alcohol and substance abuse, as well as depression. We kind of see burnout as like a continuum to depression. And healthcare workers have much higher rates of suicide than other parts of the population. So some really significant and severe consequences. Organizationally and for patients, there are also significant problems. There's been a number of studies. We actually did a systematic review of there's over 60 studies now linking burnout to worse quality of care and increased medical errors, worse safety, and there's decreased patient satisfaction. For organizations, there's also problems because when people are burned out, their productivity drops, their effort drops, and if you're burned out, you're 50% more likely to leave within the next year. And so physician and nursing turnover becomes higher. In fact, here's a survey of the Kaiser Family Foundation that shows you that about a third of healthcare workers say they'd like to quit working in healthcare, and many of us have experienced nursing shortages in our NICU, as well as other personnel, like just leaving the job and having a YOLO moment. So this is a real problem for those of us who hope that we can provide like really, really high quality of care. There's a picture of Brian Sexton, who's been like my co-conspirator in this work over the past like decade and a half, and he published this nice study here linking burnout, emotional exhaustion to disruptive behavior. And you'll see a number of these kind of graphs where essentially we divide all the answers into quartiles and then link them, like correlate them with other domains. And so here essentially are some of the questions on disruptive behavior. And if you're in the lowest quartile of burnout, you can see that you're less likely to bully people than for those that report more burnout, and or like less likely to report public humiliation, et cetera, right? You turning their back before your conversation is over, or you hang up the phone on somebody, or you make comments with sexual, racist, ethnic slurs, or even physical aggression, which like a lot of healthcare workers have experienced over the past years, all less likely if you also report less burnout. And here's sort of another example for how insidious burnout is in its correlation with what we call care context. So here's work-life balance, but essentially what I'm trying to show you here is when you think of like burnout and other domains that are really critical for good safety culture. And so safety climate, teamwork, leadership, and work-life balance, all are kind of strongly related to each other. Okay, so if you have high burnout, you tend to have a low teamwork perceptions, low safety perceptions, low perceptions of your local leadership, and you're not as ready to improve. And so all of these things hang together. This is like one kind of global context domain that hangs together, and burnout is an important part of that. Okay, what can we do about it? There's kind of two general approaches. One of them is, because we don't want to blame the healthcare workers for their burnout. Actually, healthcare workers tend to be really resilient folks. They've already gone through a lot of kind of trauma to get to where they are. So maybe we don't want to blame the people, but we just want to fix the work. But at the same time, a lot of people are actually quite like in a difficult spot, and there are a lot of things that we can do to support them. And so I think like there's been a debate within the field, and I think rather than saying like, oh, all we need to do is fix the work, I think it's really both. And actually supporting individuals is something you can do here and now, whereas fixing the work is quite difficult because in the NICU, we'll always have traumatic days. There'll always be, unfortunately, babies that are dying and families grieving. It's a hard job in many ways. It brings a lot of joy, but it's also a tough job. Okay, here's an institutional intervention you could choose to do. This is called leadership walkarounds. And hey guys, if I'm going over time, just let me know. Okay, so I'll speed up. Leadership walkarounds is essentially where an executive walks around the unit and ask, together with a team of quality improvement specialists, ask the frontline providers, how are we going to kill the next patient here? This is how it was designed initially. And this actually worked in randomized controlled trials, improves patient safety. And the really, really important part of this slide here is that it is too complicated. I'm just going to tell you the upshot. The really important part is that you have to provide feedback. Like once you ask people at the front line of like, what's not going well here, you need to, as you go off and fix it, you need to come back and tell them, hey, you told us this doesn't work. We went out and we fixed it. Thank you so much for letting us know that there's a problem. And so if you do this, if you do provide that feedback, you're going to be in a unit where you're less likely to be burned out, you have higher safety and more teamwork, and other kind of domain features that are positive, without going into too much detail. Now, the new iteration of executive rounding really is positive rounding, because just asking people like, how are we going to kill the next patient here was kind of like a, not a great way to kind of go about it, but this is how people started. Now what we do is we walk around and we ask folks, tell me 3 things that are going well here, and tell me 1 thing that we could do better. And so we really want to focus on like what's going well in our unit, because being able to appreciate what's going well is actually really important to people. And so supporting them and thinking about, what's going well in their unit is a good thing and boosts their morale. And you can see strong relations again with all of these kind of domain culture, like culture domains. If you do positive rounding, you tend to report better other domains, as you can see here, than if you don't do this. Here's another intervention. If you're not a fan of Ted Lasso, like hopefully you will be, because it's just maybe the best thing throughout the pandemic on TV. So second victim support is the second victim, like the primary victim of a patient event is the patient, right? If there's an error, the patient is the first victim and their family. The second victim is the healthcare worker who something happened to that, that those people are suffering. This is not an easy situation. And hospitals that provide support for those healthcare workers tend to also receive substantially better ratings in terms of burnout, safety, teamwork. These things already. So providing help to your workers when things don't go well is important and can be institutionalized. Right, this is data from over 400 work settings. And let's talk a little bit about individual improvements that you can make right now and in a short period of time. So this is a field of positive psychology, which Marty Seligman founded. And really the idea is to not focus on the negatives in analysis, but to focus on the positive things when they're there, not to fake positive things when they're not there, but to appreciate the positive things that are around us. He studied multiple interventions. One of them is called 3 Good Things. It's where you, before you go to bed, you think about 3 positive things and you try to write them down. If you do this just for a week, you get substantial improvements in happiness, as well as significant improvements in depressive symptoms. These are randomized trials, and I left a YouTube link there. You can kind of look it up if you want to learn more. We conducted a randomized trial, which we call WISER, where we screened. There's a lot of these tools from over 200 tools. We screened out like 5, and we provided that to folks on their phone. And essentially, what you do, you get a little video, you learn how to do the tool, and then you practice the tool for a couple of days, and then you're going to learn about your next tool. And if you do this, if you participate, and a lot of people don't, which is the problem of the personal interventions, but if for those people that do participate, again, significant improvements in burnout and work-life integration, and I'm not showing you this, also in depression. Actually, like these tools work at about the same, to the same degree as pharmacotherapy for depression. Also works for moderate depression, which pharmacotherapy usually doesn't address very well. Now, all of these things, like 3 Good Things and the other interventions, they kind of be backwards looking. There's also a tool which we want to be like forward looking, because we're coming out of this depression. We want to have something positive to look forward to. So we created different tools called the forward tool. And it is something that you could choose to do. And it's also, as you can see, it decreases impression and helps with the other things like thriving and recovery. So Brian Sexton again sort of published this, and if you're interested in this, you can access these tools and others on the website. This is all run via Duke University. You can choose your QR code, and if you get the slides, you can just do it then. Otherwise, if you're fast and you have your phone there anyways, because you're not listening to me, but scrolling on your Twitter, which you shouldn't do, then go ahead and snap a quick shot of this and try it out. All right, these things have like work too. We just came back from the Vaughan meeting. being with your colleagues and in a community of peers and celebrating with them is a good thing and supports your burnout. So shout out to them. Here's just a list of the tools. If you can write these down, you can just put those in your browser. You can offer them to a friend or your coworkers, and I think that's it. Thank you so much for taking the time to listen to me. So I'll get out of here, stop share.
Okay. Thank you so much, Dr. Profit. That was wonderful. For our next presenter, we're going to transition over to Kara Hansen, who I believe is sharing her slides now.
Okay, thank you so much, Dr. Profit. Really great information on burnout, and I'm going to talk a little bit more about some of the individual level interventions as well as just a more broad experience with psychological stress. So we know, like, the best definition out there in the literature is that when any of us sees a situation or an environment that we're in as being too much for us to deal with, that space between ourselves and the situation or circumstance, that's where we have psychological stress. And so that can show up in a lot of different ways. For some people, that's a lot of anger, irritability. Others, it's sadness and dejection. And there's certainly a lot of physical symptoms that can show up too. Again, the idea of the spectrum that Dr. Profit mentions, with, stress really existing along this continuum where some situations and the way that we show up in that situation, how things are going at home, with work, with school, whatever we're dealing with, are going to influence our response to stress and how well we're able to cope with the situation that we find ourselves in. But in general, things that we can look for: how we're eating, how we're sleeping, what our usual healthy habits are looking like if they're not looking as good as normal, or if we didn't have any great ones to start with and now they're even a bit worse than they were before. And a big one that I hear often from colleagues is just feeling like there's really no time that they're not on or working on a to-do list. So just not feeling like you can catch up, really constantly feeling like things are on top of you. Those are some of the ways that stress shows up for us and some of the ways that we can feel when we're dealing with it. So there's a lot of theory around stress that we could go into. I just wanted to mention a few because, again, just like the life events that we're dealing with, our self, our person, and who we are, what we bring to the table, that can influence how we respond to stress as well. And so it's the same reason why 5 of us could line up and deal with the same circumstance and have a different response to that very same situation. So the ways that we tend to look at things, if we tend to be more pessimistic or optimistic, if we had a strong attachment to a caregiver in childhood, or if we tended to really not have as strong of an attachment, if we typically deal with stress by avoiding things when they get hard or pretending that they're not there, or if we meet them head on, all the ways that we are kind of wired from the time that we're a pretty small human being, those come into play when we deal with stress. And we tend to slip into those old familiar patterns, especially when things are tougher than normal. So the last thing on the theory piece that I want to mention, because it's huge, and I'll keep coming back to this, is our physiological needs. If we have food, water, shelter, moving up a little bit, if we have a sense of safety, those are the biggest building blocks of coping with stress and being able to feel like, we are well, we are healthy within a reasonable expectation. And those are the things that, when we are in a crisis situation and just not functioning well, they tend to be the first to go. So they're a pretty big focus when I'm dealing with stress myself and working with people who are as well. There's definitely a lot of definitions around stress in healthcare. You've probably heard of compassion fatigue. Dr. Profit mentioned, this experience of secondary traumatic stress, and some of it is occupational hazards. The work that you all do, sometimes there's just no avoiding being around really difficult situations. And then sometimes there's systemic issues that can be addressed that make these things harder. for all of us to deal with. And I think it's really important to notice too that, the work that I do with our hospital-wide debriefing team, where we get to go talk with healthcare workers after a really hard event, we expect that you're going to have a stressful reaction to a difficult situation. That's expected. That would be an acute response, that maybe you're having a hard time letting go of it, thinking about it a lot. Maybe it's disrupted your sleep for a few days or a week. That is a normal response to a really abnormal situation. And it's really when it starts to move into being more of a chronic response that, it's weeks later, it's months later, you're still thinking about that same situation, or, just work in general is really piling up and contributing to this chronic sense of not being able to leave behind the hard stuff. That's when things really get into a bigger intervention point. And Amy will talk a bit more about that later in the program. So again, I don't think it matters a whole lot for the purposes of figuring out what's going on with you, but I know these are terms that do get thrown around quite a bit. So when we're talking about compassion fatigue and burnout, these are just all the ways that the experience of stress in the workplace can manifest depending on how long you're exposed to that stressor and how you're able to respond to that stressor. So looking at ways that we can kind of build up the toolbox of tools and coping strategies that you all have to turn to. Hopefully you're at institutions that are offering some of the resources that Amy will mention later on. So these are just a few additional ones to kind of tuck into your own toolbox, so to speak. So the Professional Quality of Life tool, this is a link you can go to, and it really walks you through as a healthcare worker, what are some of the things that you're dealing with? How are you responding to them? How are you functioning? And it's a great objective sort of measure, and as much as a self-report can be, of how you're doing and how you're feeling. And I think that's a great tool. We encourage a lot of our fellows in the NICU to revisit this every 6 months or so, because, when things get busy, it's just really hard to really keep track of how you're doing and have that self-awareness at a pretty heightened level. So this is a great way to just kind of go back and check and see, okay, like I'm still scoring, pretty well in a decent range right now, or I'm really seeing that I'm struggling more in this area. Maybe that's something that I need to give more attention to. The great thing about this website that I love, I think I'll flip my slide here too, just to mention this link that's listed as self-care tools. The QOL has a lot of really great psychoeducation links and handouts. So great information on sleep hygiene, on various coping strategies, on way to build a personal routine. Just a fantastic resource to access as much as you need it. So I'll just put a plug in for that. And when we talk about coping, there's all sorts of different ways that people cope. Some of the best ways that we know from the literature are seeking that social support, having peers that you can talk to when things are tough, having people that you can celebrate with when things are going great, and then really looking at ways that, when the hard things are happening, how are you able to endure? Telling yourself things like, I can get through this. I've done hard things before. Really looking at ways that you can kind of endure that situation, and then ways that we can actively cope too, that, we're not just waiting for things to happen, but we're actually going to go and say, I turn to painting, or I have a weekly yoga practice that I like to do. Those are things that I know I can stick to and that are going to really help proactively fill my cup, so that when things are hard, I've got a little bit more reserve to draw on. And then the emotional awareness and regulation too is a big one. Just knowing, hey, today I've really only got 20% in the tank. I was on call last night. I've got a couple of tough cases already this morning. I'm really going to have to make sure I get some time to take a break later, or whatever it is that is going to be helpful for you. I'd be remiss to not mention self-care, even though I know it's not the end all be all for coping with stress. But just to mention that, it really is important for you to take time to take care of yourself and really build that into your daily routine. So there's a couple links if this is not a concept that you've thought much about. to really look at some basic ways to take good care of yourself and make yourself more of a priority. Hopefully you're already doing that, but most of us don't do a great job of this. So I think, these are resources that we can each kind of revisit from time to time, especially as we might build good habits and then those habits slide when things get tough. And really thinking about self-care is not, I'm going to this, hour and a half yoga class today, even though that's great. And it could be a part of your self-care, but, getting dressed and taking a shower and eating food, letting yourself cry and not beating yourself up about it. Like these are all ways that we can do good self-care too. And again, I'll kind of go back to this theme of having coping strategies that you are building in proactively, as well as ones that you can use in the moments of stress when things are really tough and it's really hard in that moment. So, in general, we know that reaching out to people and having social support, moving our bodies, whether we can do every single day, and build those healthy habits that are going to serve us when things get hard. That's a huge piece of stress management that we can just kind of build in as a routine habit. The habit part is the hard part. So sticking it with something in your routine where you're going to be more likely to remember it, or using an app that's going to send you a reminder, things that really are going to automate it as much as possible. So, I have, this gratitude app that I linked, that Dr. Prophet mentioned. It reminds me at 9 p.m. every day to write down 3 things that I'm grateful for. Easy. Then all I have to do is respond to the text message. Things like that can be a little bit more automated or helpful. And then thinking about how you are going to cope with stress when it happens in the moment. So, looking through a few of those resources, if you don't have something that you already do, and maybe finding 1 or 2 things that you can keep in mind for when things are tough, having a grounding exercise, or really being able to use a breathing strategy that you like so that you can take those 3 breaths before you respond to a really difficult parent or a really hard situation at the bedside. Last, talking a bit more about support, and I know Amy's going to mention this as well. Asking for help is a big one. I walked through our break room this week and heard one of our staff saying, well, she's a nurse, like we're not good at asking for help. That's just kind of who we are. And I think there's a lot of truth in that for all people in healthcare. We are in as helpers. It's not as easy to accept help. And we really need help. So identifying what we're needing when things are hard, identifying what we need on a daily basis to take care of ourselves, and making that a priority, asking the people in our lives to help us make that happen. And then I encourage people too to really practice asking for help in really small, insignificant ways, just to get yourself kind of used to that. If I'm struggling with something on my computer and my office mate's in there, I might use that as a chance to just say, could you show me how to use this document, or whatever it might be, so that it becomes more of a comfortable thing for us to do when things get hard. We're more likely to be able to ask for help when we've done it in the smaller things too. Letting go, practicing good enough. Good is done is better than perfect. Having those sorts of mantras that in a situation that we can use them, being able to just say, this is good enough and I'm okay with that. And having those sorts of phrases that we can rely on, to let that be enough and to let ourselves be enough. Okay, and I'll turn it over to Amy.
Kara, thank you. I'm hoping everybody can hear me okay. Yes. Okay. Yes. Very good. Thank you. So again, piggybacking from what Kara just talked about, we know we might need some increased support. We know that this would be helpful. We know we do hard work in our NICUs every day. Why is it so hard for us to ask for help? And I think there are different levels of this, right? At the individual level, there may be stigma about asking for help, right? We should be strong. We've been through worse. We can do this. I'm not one of those people that's weak or that needs something. I don't have any mental health issues. I'm totally fine. There can be shame, feeling like I failed, I'm not good at this isn't the right fit for me career-wise, just really some embarrassment. And frankly, I think we have some limited role models potentially in our environments where there may not be people who have come before us and who openly share about what they've been through in their journeys. And I think it's really tough too. It's hard to ask for help. We're kind of set in our ways. We have our priorities. We have what's going on for us. And so it may be hard to think about incorporating other things. At the same time, it's also hard because, we know our priorities may not be aligned in the way in which we actually really want them to be, that we really wish we could take more time to address some of these concerns. Environmentally, we also may have accessibility issues. How do I make time for this in my day? How do I potentially, get linked with additional help with a therapist or peer support? Who has the time? And how do I go about doing that? And certainly, our job demands a lot of us and of having high expectations. So I think all of these put together make it really hard to ask for help. We are really good at the shoulds. Well, I should be able to handle it. Well, I should be able to do this. And it's really not that simple. I think we're really good at thinking about maybe the families we work with in our NICU, that maybe they need some extra help or they need to seek support. But we're really kind of lousy at following our own advice and putting that into practice for ourselves. So how do I know if I need help? How do I know where I'm at that tipping point where things are getting bad and I may need support? Again, going back to what Dr. Prophet was saying, we know this definitely has impact on job satisfaction, burnout. We need to be aware of what our emotional functioning is and our mood status if the stress is building up and it's really interfering. And that's where I think we know if we need help. If things are interfering with our work lives, our home lives, and if we're having a significant amount of distress, that isn't transient. It's hanging around. It's around for at least 2 weeks. It's more bad days than good days, not feeling like yourself. And certainly if you're having thoughts of self-harm, that would definitely be a red flag and a big alarm, that we need to make sure that we address that. Certainly, we know that in healthcare professionals, veterinarians, so on, that there is a surprisingly high rate of suicide attempt. And we want to make sure that we're really paying attention and having self-awareness about what's going on so that we can get linked. So in real life, I could give a list of all these clinical symptoms and so forth, from the DSM criteria and all that, but what does that look like when we're talking about real life, day-to-day functioning? This is when, you definitely feel like you are not on your A game, whether the home front or the work front. So being late for work, not being able to enjoy your family as much as you used to, not being able to enjoy a hobby, excessive sleeping or very little sleeping, more irritable, getting angry for no reason, really ruminating, perseverating. Sometimes we may take our work home with us. I mean that physically and mentally as well, of continuing to think and having situations from work bother and intrude into our thought process when we're off the clock. Really starting to have some numbness, not having any emotion, feeling more apathetic, socially withdrawing, not having any interest in doing things with other people, very much retreating. Some folks, this may come out in high levels of anxiety and being hypervigilant and on edge, and really not being able to relax or turn off their minds when they need to. And certainly there are risk factors out there. And again, piggybacking on what previous speakers have talked about, that this is not just a talk about our staff members, physicians, and so on, who may not be able to handle it or something within them personally that needs to be fixed. We know it is a combination of things, and we certainly know our environments are really tough and put us at risk by having long hours, potential for skipping meals, not getting nearly enough sleep or enough time for personal interests, spending time with family members, and so on. We know that there's certainly personal risk factors if you don't have much social support. And I know, especially with early career folks and fellowship, you've done a lot of moving around. It's very hard to get ties established where you are. And again, I think not having a lot of peer support, maybe being far distance from home and family, may be really tough, and certainly puts us at risk for being more vulnerable. So these are things, some of these things are modifiable. Some of these things may not be. We also know that family history and past personal history of mental health issues may make someone a little bit more at risk for having some difficulties here. Also, recent life changes, outside stressors, financial worries, all of these things can compound to impact our mental health. So what do we do about it? We know what's going on, but what do we do when we realize, that there is a problem and we are having a high level of stress and it's interfering? I placed this here, but obviously this is not the answer. We need to be talking about what are some of the other issues that we can do for ourselves to make things better and for our colleagues as well. So while we could bang our head against the wall, it certainly would not be recommended. So I want to talk about the things that we can do. And some of these are more informal or formal. I know Kara really covered quite a bit of some of these things already, so I don't want to repeat that. I'm going to focus a little bit more towards the bottom of the list, but certainly self-care, making sure that we're taking care of the very basics and starting from there. And then also thinking about those healthy lifestyle changes. But I think we also need to be thinking about our environments in which we function each day. And when we come into work, what workplace support do we have available to us? What kind of environment and culture do we have? Do we have a culture in which we can openly share when something is hard or talking about how a case might be affecting us? So I think peer support is really important, whether that's informal or a more formalized system. Mentorship support, really being able to find your people who are going to help develop you professionally, but also be mindful and maybe help point things out and protect you a little bit on the personal side as well. There may be ways in which jobs may be able to be modified to potentially increase flexibility or help maybe preserve periods of sleep or incorporate ways in which time for meals is valued and protected. But there's also that level of professional behavioral health intervention. And so I do want to spend some time talking about this, because I know here's where, the rubber meets the road. If we know we are struggling and it's really hard to get through the day and we're thinking about leaving our profession, and it may be a point where it's time to talk to somebody about it, whether that is finding a professional therapist, whether that's potentially talking to one's doctor about a potential medication evaluation. We know that these things are very effective in treating depression and anxiety, and it's important that we know how to access this. So one way certainly is to be able to talk to your healthcare provider. And these are some tips about that. We know these are not easy conversations to be had. And particularly when we're in healthcare ourselves, sometimes we do not make very good patients. But being able to be open, be vulnerable, to share when we are having struggles and that we know it's becoming more of a problem. And if we think about how do we find behavioral health support? What do I do? Everybody's telling me I should go talk to somebody. Well, who are these people and how do I find them? Generally, you're going to be looking for a therapist, and that could be across a wide range of disciplines. It could be a psychologist. Certainly, clinical psychologists provide talk therapy. So do licensed counselors and licensed social workers. So you're going to be wanting to look into ways that you might be having easy access to that. One of the primary ones that's available and generally can be free would be an employee assistance program, or if you're in a training program, there may be built-in access there through the workplace. There's also Psychology Today, which has a searchable database for whether you are interested in a certain gender of a therapist, whether you want a certain specialty area, a certain part of town. It's very flexible in that regard. I think if we're talking about how to get it covered and how to get it paid, starting with your insurance and looking at the panel of in-network providers is important. And the other way to do it is to go through your state licensing board. So for example, in Ohio, there's an Ohio Board of Psychology, and there's a searchable database there as well. This way you're making sure that you are receiving help from someone who's reputable and licensed and using empirically based treatments. We also know that there are many examples of strong hospital and unit-based support. Again, some of these have been touched upon already, but it can be helpful to be able to help create that culture where we can talk about the hard things. So having debriefings after an event or a significant death on the unit, having meetings that are maybe provider only, that we can discuss moral distress amongst staff when we're really feeling stumped or we're really faced with a complex medical situation or concerns for suffering. Recognition, gratitude, incentives, these are all excellent about focusing on the positive and highlighting what we're doing well, recognizing those around us who may brighten our day or we see provide excellent care. Holistic health sessions. I think more places are becoming very, enlightened into the benefits of complementary medicine, having yoga programs within the hospital, therapy dogs that may come and visit with staff, aromatherapy, chair massages that may be offered. I think we're going in a good direction in terms of offering this for our staff. And I think it's important to have that culture within our units that these services are not seen as, we don't need that, I don't need that, I shouldn't have to do those things, but that we take advantage of them, that even from the top all the way down, that anybody who is in the workforce is able to take advantage of those and serve as good role models for our colleagues as well. Sometimes there may be hospital-based, that's on-site professional support that have built-in clinicians into the hospital environment that are easily accessible, or also peer support networks that are a little more formalized. Again, employee assistance programs and then wellness initiatives within hospitals or within training programs that really are focused on your well-being and maintaining that. So how do we create a good culture within our unit? I think it's important that we are not afraid to start that conversation, talking with peers, fellow trainees. How do we be able to be open? And I think it's by starting that, by trying to create a safe environment, by modeling that for others. I know that can be really hard, but I think it's okay to say, boy, I'm having a really tough day. Anybody else? This family is really on my mind a lot. Can we talk about it? I think bringing those issues up, incorporating them into rounds, incorporating them into conversations with preceptors, mentors. It's important that we're checking in with each other. Also evaluating the needs, evaluating some of the barriers. What are the things that are getting in the way? What do we feel like our units may be able to do better? Is there a way to bring this up in a meeting and talk about what are those modifiable work factors that may be able to be changeable, that we could do even tiny interventions, but may make a big difference in terms of creating a more supportive environment. I think discussing with peers, I think also bringing our discussions to leadership. It's one thing to just talk to each other, but I think it's also important to engage leadership and really advocate for ourselves and advocate for the environment that we want and the team values that we need in terms of advocating for wellness for our staff to be able to maintain in the long term. Because we know the acuity may not change. Some things are going to be the way they are, but how do we help support each other? So I want to just end with tying into our title of our talk, which is You Can't Pour from an Empty Cup. Again, oftentimes we may be running on low, and it's important to know that self-care isn't selfish. It is indeed necessary. And I know maybe you seem like I need to take care of my patients, or I need to take care of myself. I need to take care of my family, or I need to take care of myself. And it's really important, I think, that we recognize that they are one and the same, that taking care of ourselves help us to be the best healthcare provider we can be. And that is part of taking care of our families and providing good healthcare. And thank you very much.
Okay, thank you so much, Amy, Kara, and Dr. Prophet. That was really wonderful. And we've got some great questions in the chat. I wanted to turn it over to Katie to help start that conversation. And the rest of the questions that were sent over, we will make sure that we get to. Also, just quick plug, as often happens with our webinars, because we've got such great conversation starters, it looks like we may go over time. And as many folks as who are able are welcome to stay on the line after 3 o'clock, but of course we want to be respectful of your time. So please feel free to leave whenever you have to, as we recognize we're at the end of our hour.
Thank you so much for the speakers today. We are really fortunate to have you all here as our content experts and helping us navigate this really important topic amongst all of our providers in the NICU. I just want to, again, just normalize how frequent this is for every single one of us. Just like in Dr. Prophet's, 2/3 of us struggle with either burnout or just different symptoms of mental health symptoms. And it's quite a normal thing when we're doing our job that we do. So I just wanted to keep on normalizing that and destigmatizing it. I think it's great that we're opening up this conversation. One thing that I wanted to mention is just how helpful it is to be able to bring up job modifications with our greater community. And I know that there have been a number of examples from large, very prominent academic institutions and private institutions of opening up these conversations and invoking change. One that I had heard recently was doing a needs assessment and finding that one of the highest reasons for their high burnout was, just an example, their call schedules, and having a period of 6 months of trial of a different 16-hour shifts versus 24, for example. I was wondering to the panel, just posing it, are there any other examples that you've seen be successful in opening up conversations with leadership that have worked to invoke positive change to support mental well-being in the unit?
Yeah, I can only speak a little bit about this from our Stanford experience. So our dean actually recognized that this is a major problem quite a while ago and put like $5 million towards developing a wellness division, essentially a center at Stanford, which is run by Tate Shanafelt. And so there's a physician side and there's a nursing side. Because we're at this academic medical center kind of construct, like the physicians are kind of hired by the university and the nurses are hired by the hospital. And so, but there's a lot of crosstalk between those two. There's been sort of very deliberate attempts over the years to consistently measure what's going on in the workforce, and then to kind of build sort of incentives for division leaders into progress on these metrics. And so it's not just that leaders, they're just like, oh, this is kind of a nice thing, and hooray if you do it, and like, don't worry if you don't. But it's being kind of put into, kind of like key performance metrics, I guess, for leadership. And so now they have to kind of think about this within their own division and have incentives to do so, which I think actually has kind of made talking about this a lot easier, because there's obviously institutional concern. Some of it developed around the idea that it costs about $1.5 million to replace a physician here. And so it's much easier and much cheaper, maybe not easier, but it's much cheaper to try to prevent people from leaving than to hire new staff. And that's probably the cost is probably relatively low estimate, because it doesn't even take into account all of the productivity losses you get when you just sort of first hire a new physician. That might not be true in the NICU necessarily, but in areas where you're like sort of RVU based, where you have to see a certain number of patients in order to make up kind of what the person who left was leaving behind. That sort of takes a while. And so there's been a lot of like impetus from the hospital to focus on clinician efficiency, which has been kind of interesting. They really want folks to not have to be as bogged down with clerical work. We still are, but at least there's they know it's not a good thing, and they want there to be less. And then there's sort of the kind of focus on the provider sort of burnout side, more on the psychological side. But there's also kind of like they go hand in hand, right? If you spend less of your time just like typing away at a computer, but you do the stuff that actually provides meaning, that helps patients, providers, as well as the hospital. So I'll leave it at that. Sorry, it was a long-winded answer.
Thank you so much for that. That was really, really helpful. Olivia, I know that there were some other questions in the chat if you want to chime in on that.
Absolutely. So before we do that, we are at 3 o'clock on the nose, and we have been trying to take a photo of our Zoom attendees so we can share this on social media just to show all of the excitement around this campaign. So if everybody that is able wouldn't mind turning on their cameras, I think Anne is going to direct us in a beautiful photo op.
Yeah, and as we just heard, one of the ways to prevent burnout is to feel a sense of connection to your colleagues. So while we do this national campaign, perhaps these little photos and kind of cheering each other on social media, while a quick and easy way is hopefully a meaningful way to kind of have everyone feel like we're all a part of something, and that we're really trying to do something relatively groundbreaking with trying to set a new standard of care throughout the past year and working forward with this campaign. So with that, if that gets you jazzed, feel free to give a smile and jazz hands or whatever pose you would love to appear on Twitter. If you don't want to appear on Twitter, then don't turn your camera on, but know that this is for social media. So big smiles, everyone. There's lots of, oh good, we're getting a couple more cameras on, so I'll give it a second for people to get with it. Okay, great. All right. All right. So with that, all right, big smiles, jazz hands. All right, and I'll do one more for good measure, just in case. All right, thanks everyone. And I'll hand it back to Olivia for photos. I have questions is what I meant to say.
No more photos, unfortunately. So one great question we had was for Kara and Amy, just to comment on if any of your time is able to be dedicated to supporting NICU staff, and if so, how much? And if not, I know at least Amy tries to squeeze in some time because I happen to be lucky enough to work with her. So how do you fit in that time to serve in a supportive role to staff as well?
Kira, I'll let you start. I'm not sure what your arrangement is.
Sure. Yes, that is actually built into my job description, as well as my colleague who's full-time in the NICU. I do like at least 3 times a week of just rounds, like coming around to our clinic, our inpatient unit, and checking in with staff. And then I just try to have a relationship with as many of our staff as possible so that they know to seek me out when they're needing some extra support. Our chaplain is really good about doing the same thing as well with a lot of our NICU nursing staff in particular. But that's really about as formal as that time gets. In addition to that, the work I do on hospital debriefing, that we just kind of go to units all over the hospital. So I have that also kind of accounted for in that 10% towards staff support.
Kara, that's an interesting idea that you have time planned out for that. That's pretty great that it's carved out. I have to say, in my situation, I'm squeezing it in where I can. I think doing debriefings is something that I think is very meaningful and I think helpful for our staff. But I also think that one-on-one support of just circulating around can be helpful in checking in, particularly when we have really tough cases or again, after a tough loss. So I do meet sometimes one-to-one with our staff, but we're lucky here at the hospital that we have a team of folks that are dedicated to staff support, and they are all mental health providers. And so they are also circulating around and they are offering their time. And that's built in, that's their role at the hospital. And so we're also encouraging our folks to use them a little bit more. It's relatively new. I don't know how much people know that it's available to them, but that is something that we are trying to link folks with and come up with some unit-based programming and things that hopefully, people will take advantage of.
Thank you both. Another question more specifically for Dr. Profit and some of his research and experiences. The group would like to know how often you recommend doing positive rounding and if there's any data on what is optimal.
So it's still an evolving technique. It depends a little bit on your capabilities, but I think about monthly is a good time frame, because like realistically your CEO or COO is not going to have time more frequently to do this, and then it also takes some time to figure out what to do in response to the advice you get. And you also have to be realistic. There's going to be some things you can't fix, and some things take more time. But it's important, like throughout this, it's important to just even let the people know, hey, thanks for telling us, and we're working on it. Even if you don't have a solution yet, you can tell them that you're working on it. Or if you tell them like, we would love to do something about this, but it's just like right now we can't, but we're keeping it in mind, because sometimes you have to prioritize things as well. So you might get, I feel like after a while you kind of hear similar things repeatedly, in terms of what's good and what needs help. So, but monthly is probably a good time.
I have one more kind of general theme of question from the group, and then if anyone else that's still on the call would like to ask anything, you're more than welcome. But I think a question or kind of, I guess, concern that folks have is that it's difficult to find professional mental health services in the community. So in the absence of those things, are there any things that you have seen staff members use as kind of a bridge to that, or any particular resources do you recommend?
I'm so excited by if there is a silver lining to COVID and what we've been through with the pandemic, one of the great things that has come out of this is the booming industry of telehealth therapy and being able to get linked with a provider who may be out of your area, but you would still be able to have sessions and you wouldn't even have to leave your house to do it. So I think there's been a lot of appeal. And there are many different ways to get linked with someone online who's reputable. You can look at their background, you can consult with them and meet with them ahead of time to see if they're going to be a good fit. So I appreciate that it's not available easily everywhere. And certainly there can be long waits, but I definitely would recommend looking into online services. Also, there are some great apps out there that are Headspace, Calm. There are different ones that are able to lead you through, evidence-based treatments and building skills and teaching strategies and relaxation techniques and mindfulness training and things that we know may be able to have impact and working on things around behavioral activation for depressed mood. So I definitely think the internet actually, in this case, can be very useful.
thanks for the advice on how to help fill those gaps. I do not have any other questions in the chat. Is there anything else that folks would like to talk about? But again, of course, we're at 3:08 now, so want to respect everyone's time. Okay, well, it looks like there are no other questions. So thank you again, everyone, for joining. We really appreciate your participation and interest in the work we're trying to do on this campaign. Have a good afternoon.
It looks like I got one more comment just as people were logging off, and it'll still be recorded. So hopefully those that watch afterwards can do that. But Barbara DeLuian had mentioned that they're working on this important topic also with parents and families as they go home as well. So I think that's a really important thing, focusing on the families, and then also that this can still impact us after families have gone home from the NICU. It's an ongoing issue, but thank you so much, everybody, for participating. Really, really excited that we were able to do this all together. So thank you for your time.
Thanks, everybody.